Great. So thank you very much for joining me today to do this question and answer session on intensive care, ventilation and COVID. My name is Benar. I'm a hospital doctor in kidney and transplant medicine. I'm also a scientist trainee in immunology, which is study of the immune system. Would you like to introduce yourself, Dr. Morgan?
Yeah, hi there. My name is Matt Morgan. I work as an intensive care doctor in Cardiff and also lead critical care research for Wales.
Lovely, thank you very much. So I think one of the questions we can probably start with is, what does COVID do to your body? What happens when you get COVID?
Well, I think the summary is a lot happens, and as the year has gone on, we've understood more and more about the effects of COVID on different organ systems. I guess in intensive care and in hospital doctors, the effects we see most commonly are those effects on the lungs, as well as on other organs like the kidneys and the heart. But classically, the reason that people come to hospital is because they're very short of breath, they're very tired and fatigued, and the amount of oxygen in their blood is very low. So that's by far the most common problems that we see.
Great. So that was my next question was, why is it that some patients with COVID need hospital? What kind of things do they receive in hospital that they don't get at home? Is there anything you wanted to add to that?
Yeah, well, I guess the truth is, we don't know for certain why some people are affected greatly by COVID and some are not. And this isn't unique to COVID. This is the case in many different diseases, actually, whether it's chronic disease or whether it's things like infection and sepsis. There's probably a genetic component, there's probably an environmental component, and of course, there's the effect of other things like frailty, like age, and like other diseases that people have.
And so, as you mentioned, some patients will need to come into hospital because they need support with their breathing. So if they need some oxygen, for example. But why is it that for some patients, that's not enough and they need intensive care?
Well, the most common interventions that people will have when they come to hospital is, first of all, if they need it, they'll have oxygen applied. And that'll normally be through a normal face mask like people are used to, or sometimes prongs up the nose, for example. And they'll be given the treatments that we know help and work in COVID. Thanks to big trials in the UK, we know that the steroid drugs, dexamethasone and others, can be hugely helpful, and there's other treatments as well. So coming through the hospital door, most commonly people will be given oxygen and the drugs which help. However, just giving oxygen through a mask sometimes isn't enough to make the oxygen levels in the blood safe, because that oxygen's got to get through your lungs. And in COVID, the lining of the lungs and the blood vessels of the lungs can have issues with them. They can be thick, they cannot allow oxygen to move across them. And it's those circumstances where people like me and other colleagues from medicine, respiratory medicine and the emergency unit sometimes need to think about other ways of getting oxygen into the blood. And that may mean different kinds of masks fitted to the face. Sometimes a tight fitting mask, which is known as CPAP, or sometimes oxygen which is pushed up the nose using quite high flow rates, a bit like hanging your head out of a window of a car as you're driving past. And those are the most common interventions which can help people's oxygen levels.
And are there any other interventions or treatments you can offer in ITU that you can't offer in a normal ward that patients with COVID are needing to receive?
There are some, in many ways, intensive care is no different from other areas of the hospital. The things we have which can treat a disease or treat an illness are the same medications as on the ward, and that may be antibiotics, it may be steroid drugs, for example. But there's two key things really that we have in intensive care. The first is different kinds of machines, and we have breathing machines which actually blow air and oxygen directly into the lungs through a pipe that is put in the mouth and through the vocal cords. And that's sometimes called invasive ventilation. And sometimes that's called a life support machine, if you like. And the other key thing we have, as well as machines, is we have time, I suppose. We have less patients than on the ward. We have nursing staff who can look after patients sometimes on a one-to-one basis. And it's those two combinations of interventions, the machines that we have, and the time and the care from nursing staff that can make a big difference.
Great, thank you. And how do you decide who is appropriate for ITU? So how do you decide who's going to benefit from going to intensive care and who isn't?
Well, the first thing to say is, we are not the boss when we decide those things. The person who's the boss is the patient. What we want to do is what's best for them, what's in their best interests. And most of the time, that's very easy to decide. It's often in a patient's best interests to come to intensive care and have treatments if those treatments are going to work.
Mm-hmm.
The tricky times are when there are treatments that we have in intensive care, but those treatments are no different than on the wards. And if it's a problem we can't fix, and that's when there's difficult conversations, honest conversations between us, other members of the team, the patient, and their family. We're not in the business in medicine of doing things if they aren't going to work. And although intensive care is a place where we care for people, we think about pain and distress very carefully, it still can be a tough place to be for patients. So if there's no benefit of going there in terms of there isn't a problem we can fix, and if going there in itself can cause problems like pain or distress, then it's not something that we would do, and it wouldn't be in the patient's best interests in those cases.
Yeah, that's completely right. Actually, it's a conversation I've had to have with my patients many a time. And is there a time frame that you normally can you give us an average time frame of how long people with COVID are spending in ITU, either if they're getting better or if they're not?
Well, what we do know is that people who come with COVID, who need a breathing machine, who need that life support machine, if you like, they stay a lot longer on average than people with other problems, other similar diseases and other similar problems with their lungs. And the average time can be measured in weeks rather than days. But what that does hide is a lot of variation either side.
Mm-hmm.
Now, yes, we have looked after some people who just need a short period there, maybe on a breathing machine for a short time. But there's also patients who have been in for a huge length of time, measured in months rather than weeks. And that's tough. That takes a toll on the body and on the mind to a large extent. So there's a wide variation, but we know it's probably measured in weeks.
Yeah, thank you very much. And just to finish off, have you had your COVID vaccines?
I'm very grateful I have. I had the Pfizer vaccine. I've now had 2 doses. I didn't knowingly get COVID in the first wave, although many of my colleagues in intensive care did. So yeah, I was very grateful to have those. The vaccine itself was just like any other vaccine. It was a scratch in the arm. I didn't have any side effects afterwards, really. And the biggest risk of having the vaccination for me and for everybody else is actually driving to the vaccination centre. If you want to put risk in perspective, that car journey, is by far the most dangerous thing that you'll do in terms of vaccination safety.
That's a very good way of putting it into perspective. And we've been doing quite a lot of work to try and reassure people, because the science is very clear that the vaccines are safe and very clear that we're now seeing how effective they really are, which is great. But is there anything you want to say to people who are maybe still hesitant about the vaccines?
Well, I think, it's absolutely okay and right to think about these issues. We should always think about safety, but I think what people need to do is put it into perspective about the other things they do in their life. Nothing in life doesn't have any risks. Every day you take risks, whether it's crossing the road, whether it's driving in your car, whether it's the foods you eat, for example. But the reason we do that is because it brings benefits, and the benefits outweigh those risks. And it's the same with the vaccination. Of course, there are risks, and you can look on the internet and find risks and other things. Those risks are absolutely tiny, and the benefits are huge. So it's absolutely right to think about these issues and talk about these issues, as long as you look at that risk-benefit ratio the same way as you do every time you get in your car, every time you cross the street.
Absolutely, and the key is to get your information from the right sources, not just anyone on YouTube.
Yeah.
Well, wonderful. Thank you very much for joining us. Is there anything you're looking forward to when we can come out of this pandemic the most?
Well, I think like everybody, it makes you appreciate how important freedom, life and liberty is. I'm probably looking forward to the simple things, actually. Seeing my family who, although I'm looking out my window and I can probably see the house that my parents live in, and yet, I can't hug them, I can't spend time with them, and similar for friends. So I think it's those simple pleasures rather than any of the other exciting things, really.
Wonderful. Thank you very much for joining us, Dr. Matt Morgan, and good luck and stay safe.
Thank you.